I want to welcome you all to the 6th Annual CFAR International HIV Research Day. We have a full cast of presentations today, beginning with our keynote speaker, Dr. Nancy Padian, and lots of presentations from people who have received CFAR money and people who hope to at some point in the future, all showcasing the international research that has been done here. It's my distinct pleasure to introduce Dr. Nancy Padian, who's been a friend and colleague for many years, dating back to a NIH review panel that we shared. Nancy has both her PhD and her MPH. She is an internationally recognized leader in HIV and STD prevention science. And she is currently a senior technical advisor at the Office of the Global AIDS Coordinator, OGAC, and PEPFAR. She's a consultant for the Bill and Melinda Gates Foundation, and she is a faculty member at the University of California, Berkeley in the Department of Epidemiology, where she's conducted research for many years. In fact, for more than 2 decades, she has developed and directed a range of research and intervention projects focused on women and girls in particular, and contraception among high-risk populations in the US and internationally, especially in Africa. With her expertise in rigorous design and evaluation of public health interventions, her work bridges traditional epidemiologic approaches and methodologies to now include the broader context of economic development, women's empowerment, and gender-based violence. So this morning she's going to be talking about implementation science and the lessons that we can learn for our research here at UCSD. So without further ado.
Thanks so much, Steph, and thank you all for having me. The content area in which I've worked for really, it's getting close to 3 decades, which is a little odd, but which has really been very much focused on issues related to women and empowerment and HIV prevention in women. Since over the last several years, really crystallized by my work at PEPFAR, I've become very interested and involved in methodological approaches for how you evaluate programs at scale. So this really is more of a focus on methods. You know, what do you do when you have a public health program? How do you know that it works? So this is really focusing on how you implement. What are the strategies for implementation rather than what the program is? It's really how to evaluate it. So today I'll quickly be defining implementation science. I'll be talking about identifying cascades for your various programs. I'll then review some major implementation science cascades for prevention to mother-to-child transmission, male circumcision, couples testing, self-testing, treatment as prevention. I'll share with you some preliminary work that colleagues of mine at Imperial College have done on modeling the care cascade. Talk a little bit about which Steph knows infinitely more than I do about applying implementation science to key populations, and I'll end by hopefully leaving you with a simplified paradigm. And the idea is that I want you to have an implementation science lens so that when you look at the work you're doing, you can think about what the implementation science questions are, how to evaluate what you're doing. Okay, so what is implementation science? Simply, it's methods to improve. Oh, wait, sorry, one thing. I'm totally happy to be interrupted with questions. Is that okay, or do you prefer it to the end?
That's fine.
Okay, that's the deal. So it's methods to improve the uptake, implementation, and translation of research findings into routine and common practice. It's sometimes called the no-do or evidence to program gap. It maintains the rigor of traditional biomedical research, but has better external validity. I'll talk a little bit about this. Whereas if you're sort of in the discovery stage or wanting to know what works, sometimes those randomized controlled trials are oftentimes referred to as proof of concept trials. Does this work? But in the real world or the larger world, and in the proof of concept, what you're doing is looking at efficacy. What we are doing is shifting to effectiveness, and that is under more real-world situations as opposed to the controlled environment of a randomized controlled trial. Does it work? Is it effective under real-world circumstances? The reason why I say is it maintains the traditional rigor is many people, including lots of people at PEPFAR, this is really a new way of doing things there, think of, oh, well, you're just talking about monitoring and evaluation. And we're not. We're talking about impact evaluation. And I could do a whole lecture on the methods of impact evaluation. But you can use methods that are common to randomized controlled trials on a population level. So you could you could randomly assign communities to the intervention or not throughout the whole community. You could serially roll things out where you're looking at your intervention compared to where the intervention has yet to be out in a country. There are various modeling techniques you use, but the idea is that you might want to call it RCT light, but it's actually RCT real world. And you're still looking at outcome using rigorous methods, but you're really looking at effectiveness as it's less controlled than what you would do in a regular randomized controlled trial. And another hallmark of evaluations for implementation science as opposed to a traditional biomedical trial is that mid-course corrections are permitted. And what I mean by that is that in a randomized controlled trial, of which I've done several, sort of once you figure out what your intervention is, it then kind of gets tucked away in a black box, and you don't touch it until the end. And that's, in fact, there are strict rules around that. Whereas in a trial for effectiveness or implementation science, you really want to learn by doing. So there are statistical techniques, there are rules where you specify things up front so that you actually have more permission to look at outcomes in advance as long as you specify that. Look at outcomes mid-course as long as you specify what you're going to do in advance, and you can make changes because what the objective there is to find out what works and what it looks like as opposed to knowing in it, as opposed to betting on what you had in advance. It focuses on how we adapt and scale up interventions from one setting to another, whether interventions are efficient and effective by the conduct of robust evaluations at scale, and it permits you to make informed evidence-based choices between competing components within a strategy or strategies for delivery. Hang on for 1 sec, sorry. The outcomes of implementation science really are two, or in a very simplified way, and that is effectiveness and efficiency. And I know a lot of you at the Gates Foundation, they call it E squared. This idea that you're looking at effectiveness and efficiency is becoming more and more in vogue. And by efficiency, which I'll talk a little bit about, it would be the optimal delivery of services, sometimes thought as value for the money, and almost always requires a cost-effectiveness approach. I realized when I was looking at my talk this morning that I didn't talk about what I'm about to say, and that is when you start thinking about these kinds of questions, it forces a new marriage. Like the research teams are comprised slightly differently of what they might be in a traditional efficacy research. I never now work without an economist, a clinician who understands the clinical outcomes, an epidemiologist. There are newer methods in biostatistics that allow you to look at causal methods using observational data if you can't randomize. Sometimes we're working with someone in engineering if we're talking about new methods of delivery, but it really is a different team and a different feel and a different membership for interdisciplinary research. So the first step is to identify your cascade. The beginning, what makes a person want to enter into, by the way, this is relevant not just for HIV, but what makes a person want to enter into health services? So for example, does he want to, do you take advantage of getting tested? What happens when you learn your results? What happens when you're linked to care? What happens when you begin treatment, if in fact you're infected? What happens if you go into a prevention program, if you're not infected? How do you stay in the system? And so on and so forth until you get to outcomes. So, but the idea is really to map out what are the steps that take to get to outcomes. And it's a leaky cascade. So the whole idea behind implementation science is to understand where there's leakage at various points in the implementation cascade and identify interventions that are suitable to stop up those leaks. Sorry. I haven't told Jeff Stryker this, but I attribute him to a lot of this work. He was one of the first people to identify the cascade of mother-to-child transmission, and this is a paper that he wrote in JAMA a few years ago. And let's see if I can do the pointer. So you can see there's, these are seropositive deliveries, and this is, when one of the big issues is, as part of implementation, it may sound odd, are the records available so that you can actually monitor the system. And there are interventions which simply are having to do with bioinformatics. Then, sorry, oh, there we go. Is maternal testing offered? Was it accepted? Was it a positive result received? Did the mom get nevirapine? Was the mom adherent to nevirapine? That is, she could have been given it, but maybe she didn't take it. So they do this by whether it's detected in the cord blood. And then did the infant, could you detect drug on board with the infant? And you can just see how the numbers go down until you get to here, but I'll show you better. So this is 91, the denominator is always the row above. So that's 91% of people were offered testing, of those for whom documentation was available. Of those who were offered testing, 96 got their results, 94% received a positive result, 94% got nevirapine, 81% of them took it according to cord blood. But overall, if you kind of sum all of that up, over about 3,200 HIV-exposed infants, only 58% had nevirapine detected on board. So there's a leakage at every step in that cascade. I'm now going to shift to cascades for other prevention modalities, and these next few slides are works in progress. This is something that I'm doing in collaboration with the Gates Foundation and Judy Auerbach and the Kaiser Family Foundation, so it's very much a works in progress. We've been trying to figure out how to map the cascade. Not everyone, a lot of people are familiar with the PMTCT cascade, but sort of applying the same principles. How would you do it for male circumcision? So, and again, these are works in progress. You might start here. The motivation to seek male circumcision, the availability of services, enrollment and receipt of the services, receipt of counseling, abstinence during the healing process, avoid risk compensation. What's not on here, which should be down here, is therefore you get the outcome of interest. That at a population level, the effectiveness is good, that people are staying uninfected. So then what we try to do, if you go back and look at each one of these squares, is map potential interventions to each one of those steps on the cascade. So I'd love a regular laser pointer. I like to walk around too much. Thanks. Yeah, and so each one of these represents a square that you saw on the cascade. These are factors that are sort of intervening, and these are potential interventions to address leakage at every step in the cascade. And rather than go through it in a lot of detail, you can see that demand creation and education and devices might affect motivation. There are issues related to the service themselves. How can you make that better? How can you create demand for the service? Task shifting is a big part of implementation science. If you increase numbers of numbers of people who want male circumcision, actually here we have it with receipt of counseling, but there's also task shifting in doing the circumcisions themselves. And again, education at the end to get the outcome of interest. So it's just focusing it, and rather than thinking, does this work? What you're doing is thinking, what are all the steps you need to take from initial engagement to your outcome of interest, mapping that, and then trying to understand what interventions would be at each step. So this is a similar thing, again, a works in progress of mapping the cascade for HIV testing for couples. So the availability of services, the demand from the couples themselves, the voluntary use, support for mutual disclosure, linkage to services, which in and of itself has its own cascades, which I'll talk about later, and support for adherence. So then this is the same process. So each one of those steps is here. what are the factors that influence this? What are the interventions that can influence the mediating factors that can then lead to a good outcome? Obviously, funding and infrastructure, it's quite similar to the other one. You have issues related to demand. I'm looking for where demand is. There's demand creation, education. This is more infrastructure. Issues related to supply, technical assistance, providers, making sure that it's easy to get there, and with regard to adherence, similarly, making sure that HIV is integrated into other programs so it's just more seamless in terms of adherence. This is work that I've done with my colleagues, also in progress, where we're trying to look at self-testing. So this is a very simplified cascade of the gaps from getting people to use self-testing and then be retained in care. And so each cascade, depending on who did it, looks a little different. So in this case, you don't know your HIV status. So how can you, what are research questions around that? And in potential, then you can think of interventions. I mean, will it be the cost of the test? How can it be marketed? How can you ensure repeat testing for those who are negative, and who chooses to, and how do you increase the demand if they don't choose it? With regard to diagnosis, what's the minimal amount of information you need to ensure accuracy and minimize harm? Because the whole idea behind self-testing is to make it easier and quicker, but nevertheless, there still needs to be some counseling associated with it. Also, how will people safe test? Where will they do it? What are the mechanistic issues that you need to consider? And also, we need to look at the cost effectiveness of self-testing versus current strategies. Linkage to care, as I say, I'm going to talk a lot about that when I talk about treatment for prevention is a huge issue. Similarly, retention in care. So, and all of this needs a careful monitoring system to be able to look at impact, and in addition to a monitoring system, have this program be rolled out in such a way that you can see rigorously whether in fact you get the impact that you desire. Okay, moving on to treatment as prevention, which is something I've done a lot more thinking about, and I'm sure a lot of you have. This has been a big issue at PEPFAR. So this is a slide that Wafa El-Sadir made, and you can see, this is her cascade. I mean, I don't know if you, I'm also not exactly sure how we're doing with time, but the big chunks really are you aware of your status? We want to do better on late diagnosis. Obviously, if we're doing test and treat, get people in earlier. The failure or linkage to care. Oh, these are sort of all the negative things. And the inability to maintain viral suppression. Basically, you have to turn all of these negatives into positives. We have to make sure you are aware of your status, you're getting diagnosed early, you are getting linked to care, you're getting on your drugs right away, and then it's good enough to maintain viral suppression. So just beginning with testing as the first step of the cascade in treatment to prevention. This is a fairly old slide from Kenya, and it's looking at the proportion of people who never tested, or so 56% of the people never tested, 28% reported that that their last HIV test was negative but hadn't repeat tested, which leads 84% who didn't know their current status. 16% knew they were positive. Now, numbers are better than this, but they're still really bad in the double digits, with the vast majority of people in sub-Saharan Africa not knowing their status. So what are some implementation science questions we can do? This is focusing on HIV testing and linkages to care. Supply-side interventions to get people to have innovative systems to attract people to want to become tested. So some examples might be performance-based financing, pay for performance, incentives, conditional cash transfers or not conditional to get, this is the incentives for the people who are delivering the service, incentives for people who are uptake the service, have delivery models that optimize uptake and increase demand, optimize linkage to care, but you have to obviously protect rights and confidentiality. And I already said some of these examples: demand-side incentives, supply-side incentives, home-based door-to-door testing, and non-medical venues as just some types of interventions you might think about. I'm sure everyone has seen this. This is the slide from Gardner's article, and this is looking at, 2 arrows. This is looking at stages. This is strictly the cascade for engagement in care, which is obviously part of the cascade of treatment as prevention, because once one is infected, this is the cascade you enter. And, oops, I thought I had it. Right. So you can just, and this is in the United States. So this is over 1 million that are HIV infected, and if you go through all of the steps on the cascade, you see that only 19% of HIV-infected individuals have an undetected HIV viral load. And the problems are at least as bad in sub-Saharan Africa, but I just came back at a meeting in Tanzania, and I'm not really sure. Well, I have not seen empirical data to back it up, or let me put it this way, there's few data to back it up, but in general, there's some belief that adherence is better there in sub-Saharan Africa, but I worry about those overgeneralizations. This is a systematic review that Sidney Rosen wrote, and this was looking at a variety of testing and treatment studies in sub-Saharan Africa, and I tried to summarize the results across all of the steps in the cascade for all of the studies she looked at, and I honestly can't remember if she looked, I think it was about a dozen. And these are all studies for whom there was denominator data available. That is to say, she could know how many people did test and then get their CD4 count, what the denominator of people should be. So who made it to stage 1 was 59%, stage 2, which is pre-ART care, 46%, began initiation, 68%. But if you look at all the way, and that is you stay virally suppressed, but of course, each study had a different study duration. It was fewer than 20%. Another issue with looking at these implementation science questions, it's an added burden to the health system. So you're switching how you're looking at things. So, rather than do a study to look at the efficacy of a drug, you might look at different models for task shifting, or different models for delivering training to health providers. Because recognizing that there is an added burden on the health system. You also have to pay attention to structural resources, centralized and decentralized care, and of course increased commodities, test kits, drugs, and supply chains. So again, it's just shifting your focus to how do things work, what do you need. Of course, there's also added for test as prevention, and for care itself, there's the added burden to individuals, which is adherence. And so their interventions might be innovative strategies for real-time monitoring, less adherent-dependent doses, innovative delivery systems that are long-acting, slow-release, like rings, implants, patches, better-tolerated projects. Shifting to some work now that my colleagues did at Imperial College. This is very much a work in progress. This was modeling that was done by Jeff Eaton at Imperial collaborating with Tim Hallett for the HIV Modeling Consortium. I have to confess, I cannot remember the source of this data, but it's empirical data based from a large cohort in Zambia, and I unfortunately can't remember the name of it. So this is sort of what you begin with, your baseline, that right now about 24% of the population is tested, 27% that are positive retained to care, 68% are promptly put on treatment within 1 year, 69% retained after 5 years. So then what they did is modeled interventions that hit at various points of the cascade, because they wanted to look at what, if you had interventions and could improve these numbers at different steps, how many deaths averted would there be, and how many infections averted. I mean, I didn't talk at all about treatment as prevention, assuming that you're all familiar with the fact that although there's individual clinical benefit for someone who's infected to be on treatment, also being on antiretrovirals vastly decreases viral load and therefore infectiousness. So it's the public health benefit in terms of transmission and the individual benefit in terms of clinical outcomes. So here we've moved up to 50. They've only done here, so it's 50%. These numbers are what you saw on the previous slide. This is 50% of the population test every year, and I think it was up from 27. So if you do that, and this is assuming they all stay in the cascade, you avert about 3,800 deaths and prevent 3,300 new infections. Again, this is modeling. Now, if you leave that at 50%, that should have been in red, but then up this, which was also less than 30% to 90% who are tested and retained in care, you actually do better. You have over 4,000 deaths averted and almost 7,000 HIV infections averted. Now, if you add this, which is 90% on treatment in 1 year, you're doing even better. Actually, I should say these are being done cumulatively, it's not this or this or this. But I was quite interested in the next slide, which is if you retain people in care, and this is retention over 5 years, it goes way up. So the punchline here, having an interesting talk with Tim and Jeff, and it is modeling data, and so therefore, although the parameters and the values of the parameters that they used for the model were based on empirical data, you also want to duplicate this empirically and see results like this, not just based on modeling. But what came out of this is whereas all of us, including myself, are really, well, I'll speak for myself. I tend to get hung up on step one, which is how do you get people to test? Because in my mind, I'm thinking, okay, where do you start? Where do you put your resources? You put it at the beginning. For a lot of people, they think this actually is the greatest loss. In many studies, we see that. So then maybe you want to put more of your resources there. And similarly, if you have test and treat, then you might be able to bypass this because you would bypass the need for pre-ART care, go right to initiation of treatment. So maybe there's where you should put your buck. But what they see is it's keeping people in care turns out to have a much more significant effect than the others. And from this, they learned what they are calling backdoor, people who enter the cascade through the back door. That is here, we'll say, and go directly to here. And the point is that although some people are retained in care by going along the cascade, I mean, that's not to say it's entirely linear. It can go back and forth. You may come in here or what have you. But they found that a significant amount of people began treatment because they themselves were sick and symptomatic. So in fact, what they did is bypass all of these steps and entered here, needing, a late diagnosis, needing care right away, were never tested, or the testing is simultaneous to the time that they come in. And there were enough people entering through the back door that this is why they speculate that retention is so important. And I've showed this model to many people, and some people just dispute just the significance of it. So I don't think that's the real issue. The issue really is by compartmentalizing this and by tracing the cascade and through modeling, and then hopefully this will be done with empirical data, you can see where are the pressure points, where do you really need. Obviously you want to do everything, but if given scarce resources, by parsing out the problem like this, it gives you a lot of help in figuring out what you want to do. Okay, so I'm going to talk about something that Tom and Steph know way more about than I do, and that is for a little bit thinking about implementation science among injection drug users. And I know that this must be a super old slide. It's from UNAIDS. It looks like Steph is going to blow beats. And this is just the percentage of injection drug users that received an HIV test, and who knows the test results. And you can just see, and I'm sure, correct me if I'm wrong, that these data overestimate this, do you think?
Yeah, right. They're no better than that now.
I mean, when I first saw this, I was stunned, because the whole idea, think about it, if we're increasing demand for services, even if you have supply, and there's issues related to stigma and discrimination, I think the challenges are extraordinary. So with needle and these, again, you got the experts of the country, or maybe even the world, in this office, so, in this auditorium. So this is, for me, really, I hadn't thought deeply about this until I started to think about implementation science. I didn't even realize that injection drug users injected more than once a day until I learned that just several months ago. But if you have police harassment, and detention without due process, bad syringes, policies that don't support coverage, and then you have issues with stigma and discrimination, If the government's against it, how can you have testing in government run, if injection drug use is outlawed, how can you have testing run in government facilities, confidentiality, poor services, on and on. And if you're looking at giving ART treatment to injection drug users, there are some places where eligibility, in fact, I may be wrong about this, Chip, but in the U.S., was that an exclusion criteria from the early days if you're an injection drug user?
If you were not able to adhere to the medication in the judgment of the investigator. In the early days, you couldn't at all. But then it became clear that if you could manage to take the medications and adhere to the protocol, that injecting drug users were going to be invited into the protocol.
Got it. But in any case, in some places, this isn't the case. Medicated assisted treatment for injection drug use is oftentimes required but hard to get into. Well, stockouts of ART are problems everywhere, but the medical assisted treatment not being widely available would be very difficult if in fact it was necessary for approval on ART, and really it's the same issues there. My favorite PEPFAR thing that I've done, where I was really excited to be part of the program, is seeing the needle exchange in Kenya, and I was so moved by that I at that time anyway, that we had supported that and given all of these issues was really great. And again, you have, in terms of working on key populations, you guys have the experts. So it's just all of these implementation challenges are so much more difficult with them. And in fact, Rich Needles is starting to really focus on that, mainly through qualitative parts of implementation science, because we're at such early stages in terms of understanding. The cascade obviously looks really different, or there's multiple cascades. Okay, so just by way of ending, the simplistic way that I think about implementation science, and it's much easier for me, is rather than have complicated cascades, is what do you need to increase demand? What do you need to do to increase supply? What do you need to do this arguably could be part of supply or not. What do you need by the way of operations research, infrastructure, dealing with all of those things, both bricks and mortar, commodities. So really looking at these three things leads to effectiveness and efficiencies. And then just closing with some potential IS questions. What are the best ways to optimize service delivery, cost effective? This is really, a repeat of most of what I've already talked about. Task shifting, vertical versus integrated service. How can we improve access, who to target? How do you identify those who are eligible? How do you create demand? How do you increase adherence and retention? And how can you optimize or amplify treatment for prevention? As I discussed before, we need thinking about this in the optimal combination of prevention programs. I try to parse out individual cascades, one for PMTCT, one for male circumcision. Most of our research now is going towards combination prevention, effectiveness trials at a population level, so you have sort of integrated cascades, and what is the best way that you can do that and ensure a smooth transition to care and treatment. So I'd like to stop there and hope that gave you some idea of what this is all about.